we'll start the next session on this instruction course, which is labeled as the pachychoroid spectrum of diseases. Over the next 7 talks, we'll be talking about everything about pachychoroid, right from choroidal imaging to the non-neovascular to the neovascular spectrum of pachychoroid. Also talk about the diseases which are related to pachychoroid, but they don't fit into the pachychoroid spectrum. Talk about the controversies associated with it. And then we'll talk about the treatments and then the algorithm overall. So I'll invite Jay Chablani onto the dais. And okay, so we have Jay Chablani with us. He's an expert in choroidal imaging, and he's from UPMC. Okay, and without wasting any further time, I'll invite the first speaker, Dr. Rupesh Agarwal. Dr. Rupesh is a well-known figure in the field of uvea, retinal imaging, and ocular trauma. He's a senior consultant at the Tan Tock Seng Hospital in Singapore, and he has more than 400 publications with expertise in ocular imaging and ocular trauma and uvea. Over to you, sir.
Thank you very much, Ramesh, for having me here. And it's a real privilege. I keep missing out every year the instruction course, but this is the first time I'm in person here after we have attempted a few times. Okay, I see it's 5, making it 8 minutes, right?
No, it's a 10-minute.
10 minute, huh? Okay. Okay, so essentially no conflict of interest related to this particular thing. We'll be covering a few spectrum of talk, and there might be some overlap, though Dr. Ramesh did try to get us together and make sure that there is no overlap. But I'm sure there will be overlap, but we'll try and see how we kind of cheese out the exact information what we need. So just to give you an idea about the choroid, and it was not till 2012 that we were able to image choroid as well as we can do it now. And these were the early days of the choroid. And I somehow got interested in the choroid when I wrote my first ever grant for $10,000 to look into just the choroidal thickness in uveitis. I thought somehow it will be helpful. And we wrote a grant and 20 patients were captured, but we could not get much information. But then somehow I was working on imaging and all, and then Pierre Skin in Moorfields Eye Hospital and Adnan Tufil, they told me to use their software, and which was a very painful exercise because one imaging will take up to 1 hour or 2 hours of processing. So I was like, oh, this is taking a lot of time to process. But just to give you a background about why people are interested in choroidal imaging or what is unique about choroid is because it is one of the richly vascular area, tightly thermoregulated, and probably one of the highly vascular supply area of the entire body, not just the eye. And therefore, there was a hypothesis that a lot of diseases in the retina and in the eye is driven from the choroidal flow, and then that can lead to the challenges here. So choroid do play a role in physiological and pathological processes, and physiology we know, and also can be used as an imaging biomarker, and that is what was our hypothesis that we'll probably be able to understand from here. And therefore, when we started looking into the choroid, and we thought, okay, this was the early days when the paper came out, and this was looking into the segmentation of the choroid, and we thought we should dive deeper. So for some of the junior attendees or the students and residents, once you start thinking about it, any particular topic, you should dive deeper and do some literature review. So first we thought we should do literature review, and we got some of the best in this field, and I got to contact Jay that time, and Jay and I, we got together and we thought we should do a good review article on this thing. And with one of the student, Kara N, she wrote this article. And in this, we investigated what are the different ways choroid can be imaged. And we have histopathology, which is not possible, ultrasound, which we've been using in my residency when we try to do good ultrasound to look into the choroidal thickness, fundus fluorescent indocyanine green angiograph. And those days, the OCT started coming up. We thought, okay, maybe let's focus on the OCT as the output for it. So we kind of ignore right now all the other things about imaging, the ICG or the ultrasound. So we'll focus on the choroidal imaging using the OCT. So this is the term which we coined in those days in 2014, 2015, called as choroidal vascularity index. And this one was after the paper published by Teiji Sakamoto and Sonoda from Japan, Tokyo, and they published in AJO in 2013. And they did not use the term, and then they did something different in their analysis, and ours was different. So we use luminal area upon the total choroidal area as the biomarker, and that we used it as the index called as choroidal vasculature index. Just to give you an idea about how did the term came up. So in this particular room, if the area of this room is X and the area occupied by all of us and in the chairs and everything is put together, then that's called as the area Y. So Y upon X gives you kind of the population density index of this particular room. So similarly here, the vessels divided by the total area given as the choroidal vasculature index. So based on population density index, the term was coined as choroidal vasculature index, which is now taken up in a big way. And these are some of the images from animal eyes, which has underwent laser, and we just thought we'll segment and then try and understand what's happening here. So these were the segmented images of the choroid, and we were trying to see whether it is getting segmented nicely. So I will say maybe 60% of the images were able to segment, but not all 100%. So a lot of times in our presentation, we show you the beautiful images, but that's not the real picture. But there are other lots of images which we don't show you because there are challenges and you don't get that beautiful segmentation. So whenever we show you, we are like magician, we just show you the good things, and not everything can be nice. But there was an attempt to improve it, and because then it gives us idea about improving. So what we realized, this can be a useful tool because this is simple, non-invasive, repeatable, quantitative, proven, and can be cheap because it can be integrated into the existing OCT machine. And therefore, Jay and I, we did a lot of work together from 2014 to 2017, around that time, and to understand what's happening. So just to give you an idea about what can happen in the choroid when it goes wrong. So in this thing, increase in the choroidal vascularity either can be because of the increase in the number of channels or increase in the diameter of the channels, as shown on these two cartoons. The decrease can be because of the loss of the vessels, either the larger choriocapillaries, the smaller one, attenuation of the choriocapillaries, or the loss of the bigger vessels. So one of that can happen. I don't know whether Jay has got into that to identify, but as of now, I'm not that successful in identifying which layer and what exactly happens. We can say that there is something going on wrong, but right now, not able to exactly say that whether which layer and whether it is increasing diameter and all. Probably that's something which I'm quite keen to kind of go in deeper. But as I mentioned to you that we had this term which was published in a letter to editor to Sonoda's article about CVI. So that's about it. But then the journey started, and over a period of next many years, numerous articles were published, and one of the article which I'm sure Jay will remember in RO 2016-2017, which we published on the CSR, and that was one of the fastest ever article on the CVI where we got together and we got that thing. But many different conditions, more than 300 in less than 5 years were published, and you can see the impact it started creating. The one thing which is good about it, it is applied in a lot of diseases, but I get worried is this is not specific. So anything you put in, it's just getting CVI getting affected. So it is very non-specific, but can be a good sensitive marker as we can see on this thing. So we had this journey. I'm not going to show you the video, but I'm just going to show you that the technical part of it. So started with image J, which was still a very semi-automated kind of thing because there are algorithms which are written on the image J and you to just use it. You're not doing anything new, but you're just trying to kind of come up with the steps how to use image J. But there is a lot of integrated portions within the image J which we use it. So a lot of people need to understand what is written there. So it was a manual. Then we went on to a little bit semi-automated. Then further improvement is the new protocols. So like medical retina, people like to call protocol. So we started calling it as a protocol A, protocol B, protocol C, protocol D. So right now we are the protocol D stage. This is again just to tell how the image J used to work. We'll not get into the video of it, but as I said, that there are certain things which are written. So we were using nib black, but we need to understand what is nib black means. Why nib black? Why not Otsus? Why not other technique? So a lot of times when you kind of do, and that's what's going to happen today is when you're going to use AI, you need to understand why AI is giving you something like that. So this is the AI for the imaging, when like a image J, where you will just get something and you really do not know. So Using this, we published some paper. Then we moved on to the bit of a semi-automated, where we created our own portal called a CVI.greet, but it's not existing. If you try to do this, this is now redundant because we moved on from CVIGreet.org, from protocol A to protocol B. Again, it was a portal where you can just go in and upload your image, and we will try to do some backend work, but still the segmentation of the choroidal scleral interface was done still with some bit of a manual attempt, because there was still not accurate. Why it was not accurate? Because the interface itself to the human eyes cannot be seen clearly, and it was very difficult for the machine also to identify where it can be there, and we had a lot of errors. So if you put in the image and you think it's automated, no, you have to still correct a lot, and that will take a lot of time. So per image it was taking up to 3 to 4 minutes, and that's not what you want. So we moved on to another protocol. And under this protocol, again, as you will see, I'll just quickly jump onto the segmentation part. So this is the portal, and you can have many different programs, many different projects which can run parallelly. And but under this, the segmentation was happening using another kind of a protocol. So what we are doing here, thinking that the choroid is a part of the semicircle, a part of the circle, so we created two circles. One circle to lie in front of the RP, Brooks membrane. The second outer circle to lie at the CSI, the choroidal scleral interface. And then you truncate or you divide, cut out the rest of the part of the redundant part of the circle and just focus on that central little, the segmented part. And that gives you the exact choroid. So it was using the two circles. So you need to understand what is the geometry, and then accordingly you can think about it. So this was one bit of an innovation which we did. But again, it is still a bit of a manual work which you need to do. Sorry, I'll just take a couple of more minutes, and then we using this, we continue to publish in different with the different collaborators and different things. We continue to improve on it, and then we came out with a little bit better protocol. And as you can see in this, but just very quickly, I'll show you. In this, we divided also the choroid into multiple layers, and parallel layers were coming, as you can see in this thing. But this was fully automated. One good thing was this was kind of fully automated. But what we got latest one, and that is not many people have seen, with the help of a third-year engineering student in Singapore, we developed a fully automated segmentation, which is giving almost 90 to 95% of the images we are able to segment, and we use some of the vision transformers. So these words are not that familiar to me. I'm trying to understand. So using a VIT model, and we are able to segment, and which seems to be good, pretty good. And very recently, on 10,000 images, it just finished the job in less than an hour. So there is something maybe interesting for us to kind of reconsider and reconvene and then see how we can do. The other work done by my collaborator, Professor Leopold, this is an independent work, though I've contributed very little in this thing, is artificial images. So he's doing some generative deep learning and came out with very beautiful paper and the work by him and Damon Wong, and using and coming up with the artificial images, coming up with the choroid. So you can't actually identify which are the real images, which are the artificial images, and then they apply the CVI techniques on that. And so this is the work which is happening in this field of it. So eventually what I want to achieve using this is to use it in my clinical practice, which we are probably there, but not yet because a lot of machines are there. I want it to be integrated as a part of my clinical practice. So that is where I want to achieve. With that, I'd like to thank the organizers for giving me the chance. Thank you.
Thank you, Dr. Rupesh. Jay, your comments on Sir's presentation. Mics.
Okay, Mike.
Thank you. Rupesh, amazing work as always. Yeah, you have been really the pioneer on this. So I think one of the things which we have learned over the time together is that it is means it was a very niche area that we never knew what we are looking at. But I think that as the imaging has evolved much more from where we started spectral domain to now where we are in swept source and with GAN networks and the diffusion models. So there is a lot to learn. The only thing I feel is that now we are getting more and more quantitative. The only unfortunate part in this journey of a decade has been that a lot of people have misinterpreted this biomarker, and the unfortunate part has been that people have been using imaging and coming up with the numbers which we know they are not accurate. So I think that as a community, we need to explain to each other that, let's not really get onto the inaccuracies, but instead just spend more energy and get to the closer one. The biggest limitation which I always thought of CVI is that we still don't have a ground truth coming from the histology, because we know histology can never be achieved in this manner. But I think that overall the imaging quality is improving, so now we are able to see much more like we have evolved. So it's still an ongoing work.
Yeah. So thanks, Jay. I just wanted to quickly comment about what Jay said very rightly about the literature and people misinterpret. What happens is some of these papers get published, and we are trying to do a systematic review meta-analysis on that. And there is a range, it's quite a wide range, and sometimes I see some of my papers also, there are some wrong information. It is very difficult to take out that information from the published literature. So if you're not quite sure, if you think something is wrong, do not publish, because once it is there in the literature, it will stay, and then whether it is in the whichever journal, so then it will affect people's understanding, because people are reading it. When we do systematic review meta-analysis, you see so much of variations, and you really do not know to whom to believe, whom not to believe, and it affects people understanding and then the people who are practicing.
What is Haller's index?
Hilus?
Haller's index.
No, I haven't heard. Maybe we would have picked up the Hilus vessel. I haven't heard this. Maybe he would have known. But I'm not aware.
In earlier days, when we were looking into the choroid, and then we figured that the pachychoroid was just becoming one obvious entity. At that time, we started separating the large choroidal vessels from the inner choroid. So I think we published this maybe 6-7 years ago, where we were automated segmentation, where we are doing and separating the larger choroidal vessel, and that actually was one of the steps where we have now achieved, after 12 years of work, now we have achieved the 3D segmentation of the choroidal vessels. So now when we are now able to separate the Heller vessels, and where we have set up the diameter as more than 100, but we have still not reached to the medium choroidal vessels as just separate index, and we are still not there yet to image the choriocapillaries. So only the large choroidal vessels are in our hands so far.
Because many times the Heller vessels could be dilated, and the choriocapillaries could be fine, and the patient could be sort of asymptomatic or uncomplicated pachychoroid. Till we can really image the choriocapillaries in a better way. So
Yeah.
I think that could be, then only it could give us some idea.
Yeah, because these are the steps evolving. So the things will continue to change, and we'll probably reach one day. So I always see that things are evolving. Might not be that accurate, but at least there are steps moving forward. So I'm sure one day we'll reach one day.
Yeah.
Maybe in our lifetime.
Thank you. So next I invite Dr. Rupal. She'll be talking on the non-neovascular pachychoroid spectrum, and she'll make us understand those subtle changes which happen in the pachychoroid diseases.
Good morning, everyone. Thank you, AIOS and Dr. Ramesh sir, for this opportunity for presenting in this IC today. So today I will be covering the non-neovascular pachychoroid spectrum. Pachychoroid, by definition, as we all know, pachy vessel is focal permanent dilatation of the choroidal vessel in the Haller's layer, causing attenuation of the overlying satellars and the choriocapillary layer, which with or without RP abnormalities and with or without increase of the choroidal thickness. Pachychoroid spectrum, it is a group of disorders characterized by an abnormally thick choroid with distinctive vascular alterations. While much attention has been focused on the neovascular complication, the non-neovascular entities often manifest subtly, but can provide critical insights into the choroidal pathophysiology and long-term evolution of the disease. So these are the non-neovascular entities that we know of. First one is the pachychoroid pigment epitheliopathy, central serous chorioretinopathy, peripapillary pachychoroid syndrome, and the focal choroidal excavation. So I'll be dealing all of these in detail. Pachychoroid pigment epitheliopathy, it is an asymptomatic condition, or it is often seen in young individuals. It is also called as the formifruste of CSCR. The fundus features in these include a loss of fundus mosaicism and a red diffuse posterior pole appearance due to the pachychoroid feature. RP changes are often found in the macula, and sub-RP deposits can be seen. SDOCT reveals a thick choroid, small elevations of the RP representing the RP hyperplasia and sub-RP drusen-like deposits, small serous PEDs, and the outer nuclear layer thinning. Fundus autofluorescence reveals a mottled hypo and hyper-autofluorescent areas, which are seen in the areas of the RP changes. So this is an OCT image of pachychoroid pigment epitheliopathy. As you can see, there is a underlying pachychoroid vessel, overlying which you can see the RP alterations. So this is the FFA and the ICGA of the PPE. As we can see, there is hyperfluorescence seen on the FFA as well as hypersynescence seen in the ICGA due to the increase in the leakage from the dilated choroid vessels. Then a word about pachydrusens. These are drusenoid deposits which are large in size, more than 125 microns, which are seen in the context of pachychoroid vessels. These are seen as isolated, scattered, yellowish-white deposits beneath the RP layer, mostly concentrated on the posterior pole. The prevalence of pachydrusens is around 41% in PPE, 60% in CSC, 61% in PNV, and 70% in PCV. So it can be considered as a potential risk factor for disease activity in pachychoroid spectrum of diseases. So the second image shows the pachydrusens. Next, a word about central serous chorioretinopathy. It is a condition which is characterized by RP alterations along with the serous PED and SRF collection. Here, the patient presents usually with reduced vision, metamorphopsia, and micropsia. Clinically, it is seen as a serous detachment at the macular region. It can present either in the acute form or chronic form, and although typically self-limiting, recurrent episodes can be there, which can be vision-threatening. This represents the pathogenesis of CSCR. It can be due to the increased inflow and the decreased outflow. Increase in the corticosteroids and epinephrine levels leads to choroidal hyperpermeability, which leads to thickened choroid and collection of fluid under the RPE, which results in a serous PED, and a rip in this PED, which will lead to collection of fluid in the subretinal space. Then, due to the decreased outflow, the pachychoroid causes the compression of the overlying satellars and the choriocapillary layer, which leads to the retinal pigment epitheliopathy, which is a dysfunctional RPE, which leads to poor absorption of the fluid from the subretinal space. The OCT characteristics of CSCR include, in the acute form, we see a serous detachment with or without a serous PED. In chronic forms, we see a shallow, broad detachment with outer retinal atrophy and cystoid macular degeneration. FAF shows areas of hyper or hypoautofluorescence related to the RP changes that are seen, and also vertical gravitational tags of RP hypopigmentation are seen. FFA in the acute form can reveal an ink blot or a smokestack leakage, and in chronic form, it will reveal multiple indistinct leaks within the granular window defects. ICGA will reveal a choroidal hyperpermeability with the dilated vessels. This is a case of CSCR. As you can see, there's a serous PED with SRF collection at the macular area. 1 month later, we can see there's a decreasing SRF. Here we did FFA ICGA and found a focal leak, and since it was an extrafoveal leak, we went on to do a focal laser in this patient, and there is a good resolution of the SRF that is seen. This is another case of CSCR. Initially, we saw drusen-like deposits, and then a month later, the patient presented with a serous detachment. And on FFA ICG, again, we found a focal leak. The patient again underwent a focal laser in this case as well. This is a patient with a chronic CSCR. As we can see, there is a outer retinal atrophy with cystoid macular degeneration and Pachy vessels underlying. We can see these diffuse mottling at the macular area, hyper and hypofluorescence. Here, the patient was started on eplerenone because there was not much of a visual improvement that we could have expected in this patient. However, after treatment at 3 weeks, there was some resolution that was seen in the intraretinal and the subretinal fluid as well. Next entity is a focal choroidal excavation. It is an asymptomatic condition. Sometimes the patient can present with subtle visual distortions. These are areas of localized choroidal excavation without any scleral ectasia or thinning. On imaging, we see that there is choroidal thinning with an area of excavation with an intact neurosensory retina. There are two types to this. There's a conforming type and a non-conforming type. In the conforming type, we can see that the photoreceptor layer and the RPE have approximation, and whereas in the non-conforming type, we can see a cleft in between the RP and the photoreceptor layer. We call this as the hyporeflective cleft. The conforming type is mainly due to the retinal elasticity. So initially we can see the conforming type, which can later progress to a non-conforming type, which would lead to a detachment between the RP and the photoreceptor layer. The non-conforming type has an inverse RP detachment, which causes a compression of the choriocapillary layer, which causes injury to the RP Brooks complex and can predispose to CSCR and CNV. Next, a word about peripapillary pachychoroid syndrome. The choroidal thickening associated with the intraretinal or subretinal fluid, which is extending from the temporal disc margin to the nasal macula. It is often associated with hyperopia, short axial length, and choroidal folds. The pathogenesis of PPS is that there is peripapillary choroidal congestion, which will lead to RP dysfunction and SRF accumulation. The other proposed mechanism is that there's lack of RP around the optic nerve head, which leads to direct transmission of the choroidal hydrostatic pressure into the inner retinal layers, which leads to the SRF and the IRF collection. These are the images of the same. In summary, I would like to say that the non-neovascular pachychoroid spectrum as discussed includes PPE, CSC, FC, and peripapillary pachychoroid syndrome. Subtle clinical and imaging findings require a high index of suspicion and careful multimodal imaging. And early recognition and follow-up and timely intervention reduces the risk to progression to the vision-threatening neovascular complications. Thank you.
Yeah. Thank you, Rupal. We have Muna madam in this room, and ma'am, I have a question for you. Would you be looking at a pachychoroid pigment epitheliopathy in a different way? Would you be treating those cases of pigment epitheliopathy very early in the disease so that you don't want a neovascular complication developing out of them? Or you want to just keep observing them? And are there any imaging markers which actually will tell which cases will go from a non-neovascular stage to a neovascular stage in this?
Yeah, at least I don't tend to over talk to the patient about this, because we know that as it is, some of them are a little anxious. I make a note of it in my file. I make sure I look at all the images. I give them an Amsler and I say, come and see me, because you may develop AMD-like features earlier. But I tend not to, over-explain things to them, because then they move from doctor to doctor, they wonder what to do and all that. So this is something I just make a note in the file and say that we need to look out. But I really don't know whether we are looking at any biomarkers as far as progression is concerned. I don't know about Jay.
Jay, your
But
thoughts?
just
Any
I just make a note in the file and I tell them watch out for early AMD. That itself makes them worried, so I don't tell them too much.
I like this approach. The only thing I specifically look for, if you're, I think for the audience, the most important thing is to identify PPE, because many a times we don't try to even understand whether there is a pigment epitheliopathy or not. And I'm sure all of us have seen that these patients are always thrown into macular degeneration and told that it is AMD. At least in the West, it is very common to put everybody in the AMD thing. The one important thing which I really like to see in these cases, carefully on the OCD, if there is any DLS. If I'm seeing any DLS associated with PPE, which we diagnose on autofluorescence, then I think then stepping up and getting an OCD angio, making sure there is no new vessels. It is possible that you can have a DLS without new vessels. So just to a little bit more thought into this, and what Madam said is the right thing, that don't talk too much, follow them up just closely. That's all.
Can we have one more mic, please?
No, I'll okay. No, I actually, when you said biomarkers, any patient with CSR nowadays, even if they're around 40, if I see even one yellow spot anywhere in the posterior pole, specifically away from the fovea, I'll get an Octa straight away. So for me, it's not anything extra that I'm doing for the patient. I may not do an FFA ICG, but that is part of my evaluation for any CSCR patient.
Yeah, thank you, Rupal. Next, I invite Dr. Naresh, sir. He'll be talking to us on the neovascular spectrum of the pachychoroid diseases and telling us how to identify and manage these vascular changes. Madam, please come in front, ma'am.
A very good morning to one and all. I will be speaking on neovascular pachychoroid, identifying and managing the vascular changes. So this is just a sort of overview. So you have to remember that the venous drainage system is divided into 4 quadrants, and from each quadrant, the venous blood is drained into the respective vortex vein, and there is no intervortex anastomosis most of the times. So basically, there are concerns that it could be a heritable anatomical predisposition some patients have for pachychoroid spectrum, because even with a sort of congested hyperpermeable choroid, not all patients develop the disease spectrum. So there could be overload of the halar veins, and then there is a compensatory mechanism that sets in. So, and the RP is able to overcome the chronic fluid overload, and these patients may not progress further. So we don't know what really triggers some patients to develop symptoms and signs. And once there is not able to compensate, there is a decompensation. You can get dilated halar vessels, and then the overlying satellars and the choriocapillaries get affected. There is a ischemia that sets in, and you get all sort of complications like you can get CSCR, PNV, PCV. So basically, the dilated vessels that you see in PNV could be the dilated halar vessels. So there's just a vascularization, there is no aneurysms. And when the aneurysm develops, we call it as PCV. So this is the whole gamut how it progresses. We'll go to the PNV. So this is refers to neovascularization in eyes with thick choroid, and there is no aneurysmal lesions at the end of the vasculature. And whenever you see a flat fipid, that is flat irregular PD, you have to rule out there is no neovascularization, and Octa is very good for picking such cases. And you have to remember that these cases can develop into PCV also. So this is one of the case. Here you can see there's a flat irregular PD, and you see here this is a halar vessels. So most of the time where you see the fipid, you will see the morphology is different. So look at these vessels, because the thickness could not be uniform. Sometimes it could be localized and focal. And there's a co-localization. Wherever you halar vessels, on top you will see the fipid. And if you see the FFA, you don't really pick up the neovascularization. But if you do Octa, you see the vasculature in a very nice way. So this could be that why Octa is sensitive is because they are in one plane, the vessels are more mature, and there's no drusonide material, so segmentation is better. So that's why you get better images, or why the Octa is better to pick up neovascularization. And the patients may need less anti-VEGF because there are lower levels of VEGF, and then you have to rule out whether the leakage that you see is purely from the membrane neovascularization or CSR component also is there. So always do an FFA. Sometimes you may see a focal leak. So there could be a combination of both, or one could be more playing a greater part. So try to rule that out. This is one of our cases, 39-year-old male, chronic CSCR, 6/9 vision, and you can see there's a flat irregular PD, DLS, there are halar vessels here, and the Octa picks up the neovascularization here. So the patient received 2 anti-VEGFs, and the patient did well. This is another case. The patient did not really do well. Even with 6 injections, it's not getting dry. So I think PDT could be one option in this, but the availability is an issue in India. And then we come to the PCV. So basically, you need to rule out what you're dealing with, because whether it's a neovascular AMD or PCV. So there are some pointers. There's a higher incidence of SRD, greater SRD height, less interretinal edema. So all these things can lead you to the diagnosis of PCV. Basically, it is a type 1 variant. So earlier we used to think that the polypoidal lesions are deep-seated, but actually they are just at the level of the RP and the Brooks. So the layer in between, all things happen. So this is one case of, you can see on ICG how well you can see the BVN. These are the polypoidal lesions. Here also you can see a big BVN with polypoidal lesions. OCT also is a good way to at least pick up that, or you could suspect that you're dealing with PCV. So you can see there's a large PED, there's a notch here, and this could be PED harboring the polyp. So this is another case. So you can see there's a subretinal lesion here. OCT, you can see a flat irregular PED with SRF, and this is the ICG. And fast octa also is very good to look to the extent of the VVN, and it picks up the polypod lesions also. And this is the corresponding octa. So you can see the BVN is so nicely seen here. The polyps are not well seen on octa. So various classifications are there, type 1, type 2, type 3. So that will tell us the prognosis also. So this publication also is there. So this is one of our cases. Both eyes, there is a subretinal lesion here, and there was a NSD with PED, and the patient was diagnosed to have PCV. So you can see there's a small leak here, CSR type leak. There's a polyp, bunch of polyps, and this is a flat irregular PED. So both eyes had PCV, and the patient underwent multiple injections in both the eyes, and unfortunately in the left eye there was a rip. So one thing you have to remember is that sometimes serous PEDs also can rip. It's not always that it has to be a fibrovascular PED. Most of the time rip happens if there's a harboring a CNVM, and it usually happens after the first couple of injections. When the membrane retracts, it can cause the RP to rip. But in CSCR, if it's a large serous PED, there's a sudden exudation, that also can cause a rip. So there's a large rip the patient developed. And the other eye also had a large PED with fluid, and then we gave brolucizumab, and the patient is doing well. This is another case. You can see there's a subretinal bleed, and there's a large PED with subretinal hemorrhage. The patient underwent pneumatic displacement with anti-VEGF injection. The other thing is that if you see such a large area, around up to 11 to 20 disc area of subretinal hemorrhage, there is a higher risk of breakthrough vitreous hemorrhage when you inject gas. So this patient developed breakthrough vitreous hemorrhage, and then I had to take for surgery, and then the patient did well. This is another case. You can see the PED and the corresponding ICGs, and this patient also underwent gas displacement, and then the patient did well. So basically, the level 1 evidence supports the use of anti-VEGF monotherapy or combination therapy, but studies have shown that combination therapy could be better. It has a better closure rate of the polypoidal lesions, but the PLANET study shows that aflibercept is as good as PDT. You don't have to really do a combined. If you're using aflibercept, that is quite good. And the Hawk and Harrier also showed that the brolucizumab is as good as aflibercept in the management of PCV. So there's a link between CSCR, PNV, and PCV. So PCV can develop at the margins of long-standing type 1 CNV. And by a study by Adrian Fung, he showed that 36% of their patients with chronic CSCR and type 1 NV went to develop PCV. And this is publication from Dr. George. So 3.7% of the PCV cases had typical CSCR leak in the same eye. And there could be some histological variations why some patients, they don't develop the typical neovascular AMD. The RP or the Brooks could be thick. So the vasculature remains underneath that, becomes more mature. It could hyalinize, and you can get PCV-like features. So to conclude, multimodal imaging is important. Recognition of the pachychoroid state is essential for disease prognostication and management. And there are a lot of management options. I think now looking at the new data available, we could think of vortex vein decompression or some things, because whatever we are doing, anti-VEGFs, they don't really remodel the vasculature. The hyperpermeable and thickened choroid remains there. Anti-VEGFs reduce the exudation, but we are not treating the basic problem. So there is I think time has come that we should look at more sort of surgical managements and see how it goes. And we need longer follow-up studies to assess the long-term visual outcomes and recurrence rate. We need more imaging biomarkers so that we can prognosticate and we can look at the treatment response. Yeah, thanks for a patient hearing.
Thank you so much, sir. My question is that, is there a way to differentiate between a type 1 AMD CNVM versus a Pachy CNVM? Is there a difference in the clinical characteristics which you have and the anti-VEGF molecule of choice and the dosage regimen which you would choose?
Excellent question. I think that we are still learning about it, but the more understanding, which what I do personally is that because I see a lot of Caucasian patients, so first thing I look is the choroid. If I see a choroidal vessel, large choroidal vessel decompressing the inner choroid, and then there is a type 1, then I'm really going to push that into either a pachychoroid related CNV or PNV. If I don't see a larger choroidal vessels, and in addition to that, I see a typical signs of AMD, drusen, ooze, or you see hyperreflective dots. So then I would consider that as more a type 1 related to AMD. What I have realized, I would love to hear from others, that with PNV cases, the disease is very localized, but in AMD cases, the primary pathology is much more distributed because you are seeing drusen there, you are seeing SGT, you are seeing some evolution of the drusen at different stages. But when we talk about PNV, it is very much localized due to the larger choroidal vessel underneath. Do you think I'm looking at it right?
I don't know, because we don't see that much of SDD here. We do see SDD, but then now if I see SDD, then I show my fellow this is SDD. Because I think we don't see that much. But we don't see that much drusen in our AMD patients either. I don't think it'll influence my choice of injection as long as they get it.
Yes.
Sorry, I didn't answer the second part. Choice of injection, we have very limited choice, yes, but if I'm seeing something PNV, then I'm thinking about really starting somebody on HD or with faricimab. That is for sure.
Present scenario, if the patient is not responding to anti-VEGFs, patient has PNV, what options we have?
I don't think PNV patients really do that badly. It's more of a very indolent course. So I think if there's a little fluid and vision is maintained, I don't go further. But I would be more aggressive if they have a large pigment epithelial detachment or something, then I would be more aggressive. But PNV is generally a little indolent,
I think we are all underdiagnosing exudative PCV because in the one.
Yes.
So we only look at subretinal hemorrhage, then we suspect PCV.
Yeah.
So I think we should keep that also in mind.
And you can do it fairly well with a B-scan OCT also now. So the picture you showed, those sub-RP hyporeflectivity is very typical of.
So now I invite Nikita to talk about diseases which are related to thick choroid but beyond the pachychoroid spectrum.
Good morning, everyone. I'll be speaking today on etiologies where often choroidal thickening is more overlooked. Let's skip this part. We have already revised anatomy of choroid. Any change in its morphology or function can lead to choroidal thickening. The term pachy is actually derived from the Greek word which means thick. So thick choroid is referred to as increased in choroidal thickness more than 300 to 350 microns in adults, which can actually vary with age, gender, ethnicity, and many other factors. Choroidal thickness can decrease with age. It can be thicker in males, and it can have higher baseline values in some groups. And it can be thinner in myopes and thicker in hyperopes. It can actually fluctuate throughout the day. And different OCT machines can reproduce different measurements due to different algorithms. So a Beijing eye study has given few factors where subfoveal choroidal thickness can actually increase. So this is where we actually understand when to consider choroidal thickness as pathological. So there are other mechanisms beyond pachychoroid where choroid can cause thickening, which we'll be discussing in the further slides. So the etiologies can be divided into inflammatory disorders where we see in weak age disease, posterior scleritis, and sympathetic ophthalmitis, and in vascular disorders where we see choroidal hemangiosis such as in Sturge-Weber syndrome, and mechanical disorders such as uveal effusion syndrome with or without nonophthalmos. And it can be also idiopathic. This is a simple flowchart. We'll come back to it later. In inflammatory disorders, the primary mechanism is choroidal cell infiltration with inflammatory mediators, and then it causes exudation, where you can see the subretinal detachment slowly. So this is a quick example of VKH, where you can see the subretinal detachment in both eyes, especially in the right eye, where you can see the optic nerve edema, and left eye, you can see the subtle detachment. This is the OCT, where you can see the posterior vitreous cells, subretinal detachment with fibrinous septa and with RP undulations. And in both the eyes, you can see the choroid is very much thickened posteriorly. ICG is very pathognomic in this disease, where you can see the dark dots, hypocyanosin spots, which correspond to the choroid granulomas. And this is reported literature where in long-standing VKH diseases, they found that choroidal thickness especially increases after the recurrence of anterior uveitis. Here is a clear example where in the picture A, the choroidal thickness is normal, and after the uveitis recurrence, the choroidal thickness has increased. And the next disease is posterior scleritis, which is a painful form of scleral inflammation, where the inflammation of sclera is followed by the choroidal thickening. This is again an example of posterior scleritis, where you can see subretinal detachment in the right eye. The main difference between VKH and posterior scleritis on OCT will be that there won't be any RP undulations, but you can see the subretinal detachment, hyporeflective dots, along with the choroidal thickening. One of the key features of posterior scleritis is you will see the choroidal thickening on B scan along with subtenon fluid. You can also see T scan, which is not very evident in my case. There is one study with, on choroidal observations in posterior scleritis, where they have given treatment with systemic and topical steroids, where they have observed from day 0 to day 216 that choroidal thickness have been decreased with the treatment. The next disease is mechanical disorder, which is uveal effusion syndrome, which can happen either idiopathic or secondary to nanophthalmos. Primary mechanism of choroidal thickening in this is impaired transscleral outflow, which is due to glycosaminoglycans accumulation in the sclera, which causes the increased resistance and leads to choroidal venous congestion. This is a case where right eye you can see the choroidal folds with fluid at the posterior pole. The axial length of right eye is 15 mm and the left eye is 16 mm, and you can clearly see on the B scan that there is diffuse thickening of the choroid. This is the OCT. In the right eye, you can see a posterior vitreomacular fold along with subretinal detachment and very thick choroid in the posteriorly. On FFA and ICG, we usually see hypofluorescent spots, which are usually corresponding to leopard spots. And this is a vascular disorder, Sturge-Weber syndrome, where you can see choroidal hemangiomas along with phacomatoses. The primary mechanism here will be a vascular proliferation, which increases the vascular volume and leads to choroidal thickness. In this right eye picture, you can see that there is an orange mass lesion on the posterior pole. This is the corresponding OCT where you can see the mass in the choroid, which is actually showing as increase in the choroid. To summarize, these are the mechanisms and the key features in each disease, where in VKH, in all diseases, the choroid is thick, but the key feature in VKH will be bilateral serous detachment with uveitis. And in uveal effusion syndrome, it is very thick, along with nanophthalmos and exudative detachment. Posterior scleritis, you can see it is painful, and T sign will be very pathognomic. And in Sturge-Weber syndrome, you will see hemangiomas. Treatment should be tailored based on the mechanism. In the VKH, you will give systemic and oral steroids. Early addition of immunosuppression will prevent recurrences. In the posterior scleritis, immunosteroids along with the steroids again, and always OCT for the response of the treatment. Uveal effusion syndrome, observation in mild cases, or surgical sclerectomy or scleral windows to relieve the fluid. In the hemangiomas, usually you'll go for radiotherapy or observation in asymptomatic cases. The key takeaways: identify the cause of choroidal thickening and its etiology, assess their symptoms, use multimodal imaging to guide the diagnosis, tailor the treatment based on the mechanism, monitor the treatment with the imaging. Thank you.
Yeah, so we'll have a discussion on this topic along with the treatment algorithm, and Pratibha shows the treatment algorithm. In the meantime, we'll keep the controversies for the last. We'll have Vishma talk about the treatment horizons, the innovative and the conventional approaches to pachychoroid. Dr. Vishma Prabhu's presentation.
Good morning. Sorry for the delay. I would be focusing on the conventional and innovative recent approaches to pachychoroid. We already know the spectrum includes the exudative neovascularization and atrophic changes, and the common pathogenesis route involves the choroidal congestion, choroidal vein hyperpermeability, and choroidal vessel thickening. Now, this has been beautifully explained in this article in AIOS2025, where there is congestion of Haller's vessels because of any anatomic predisposition like thick sclera, and along with the triggering factor, which go in for compensatory attempts like a choroidal vein dilatation. It can lead to a stabilization or decompensation and form a vicious cycle of choriocapillary impairment, RPE dysfunction, and outer retinal damage. Why is the treatment evolving? Whenever there is choroidal congestion and hyperpermeability, is there any role beyond VEGF? Now, when there is increased choroidal venous pressure and hydrostatic imbalance are key pathogenic drivers here. VEGF targeted alone does not resolve these underlying factors, always leading to some persistent SRF. Photodynamic therapy, also knowing that some patients have some complications and limited availability, so we need some choroidal modulating agents such as mineralocorticoid antagonists and novel anti-inflammatory therapies. Now, there is a mixed response to anti-VEGF therapy. PCV and PNV are not purely VEGF driven. We know that some non-neovascular AMD like PNV always have some persistent SRF, and PCV sometimes always need some combination therapy like photodynamic therapy and anti-VEGF. Now, there is always a long-term anti-VEGF burden and treatment fatigue in case of pachychoroid diseases. And is there a role of inflammation complement activation? Now, we know that chronic CSC and PCV show inflammatory components in addition to vascular dysfunction. Steroid-induced CSC and non-resolving CSC suggest some inflammation, and some emerging therapies which are in role is some factor D inhibitors and corticosteroids. Photodynamic therapy always has its complication like choroidal ischemia and unavailability in many centers. There is some modification in PDT like half dose or half fluence PDT. Now, the treatment approaches, we should always look in for 3 target approach. Like if there is a choroidal congestion hyperpermeability, conventional technique would be lifestyle modification, and innovative would be mineralocorticoid antagonist. For neovascularization, anti-VEGF therapy, and recent techniques would be sustained release VEGF inhibition and gene therapy approaches. And inhibition of choroidal inflammation, the recent one is corticosteroids and factor D. Now, going to the innovative treatment approaches, emerging anti-angiogenic and anti-fibrotic molecules like tyrosine kinase inhibitors. These are the upcoming sustained release approaches. The novel choroidal modulating agents like the mineralocorticoid antagonists and the PDT modifications and subthreshold lasers. Gene therapy and long-standing anti-VEGF, the port delivery system, and the recently published RGX314 gene therapy. can be used and complement and inflammation targeted therapies like corticosteroids and factor D inhibitors. Now, in this article, which was recently published, shows us that there is a role of inflammation along with venous overload and choroidal congestion. They show 20 eyes with a good improvement in the vision following dexamethasone implant, and they proved that morphological resolution and visual improvement with dexamethasone monotherapy. Now, is there a role of surgery? Now, to experiment on this, we did a small, we took a case of chronic CSER patient who was a treatment-naive 48-year-old male, and on ICG, it clearly shows some Pachy vessels and choroidal congestion in the superinasal quadrant. So, our plan was to do a scleral resection in this case. So in this video, in the supranasal quadrant, we took 2 flaps, partial thickness, and we scraped, once we completed these flaps, we scraped through till we saw the uveal tissue. And this was post-surgery 1 month. We did not achieve any much improvement on OCT, but on ICG, it did show us some decongestion. Now, the treatment algorithm proposal is in CSE, is there a first-line PDT or micropulse laser, anti-VEGF if CNV present, and combination PDT and anti-VEGF in case of PCV, long-term anti-VEGF and port delivery system in PNV, or observation or subthreshold laser in the shift from VEGF-centric to choroidal modulating therapies. Now, pachychoroid diseases involves choroidal vascular dysfunction beyond VEGF. Treatment strategies are shifting towards personalized and sustained and choroidal targeted approaches. The future lies in integrating anti-VEGF choroidal modulators, inflammation-targeted therapies, and novel drug delivery system for optimized patient outcomes. So we are in an exciting era where conventional therapies are merging with innovative treatments to redefine pachychoroid management. Thank you.
Thank you, Vishma. I have a question for the panelists, and I want to know, where do you all place eplerenone or Eptus in the treatment protocol itself? Because we have faculties placing eplerenone at different stages. I give it for acute CSC. Some people give it for chronic CSCs. Where do you place eplerenone in the treatment algorithm?
So, I think that that's what we were talking about. At least in CSR or pachychoroid, it's such a challenging disease, and I think that each patient has a separate mechanism and why this has happened. So that's why we see such variable response to variable therapies. So eplerenone experience, what I have had since 2015, is ranged from excellent response to no response. So I don't rule out eplerenone completely. Even the Vichy study says no. Because again, the phenotype or identifying the right patient for right therapies is still out to the jury. So we don't know that which patients are going to respond to where. So I don't rule out eplerenone completely, but I use it primarily as a combination therapy, or okay, let's try this if it works. And again, when we start, we don't know that whether it should be a 25 milligram once daily, twice daily. I have given patients up to 75 milligram, and it works. The minute you start tapering, the fluid comes back. So it's so much to learn, and I think that this is like very challenging situation. I agree that if somebody here from UK will immediately jump in that the Vichy study clearly shows so-called randomized trial has not proven its role, but at the same time, my argument is that those patients were phenotypically different. So we need to identify the right phenotype for the right option.
And I also have a patient with recurrent CSER who is on 100 milligrams Eptus, but that's being prescribed by his endocrinologist because he has hyperaldosteronism. So there are a lot of things we may not know about the patient. So, and this man with 100 milligrams is not getting better. He keeps throwing up episodes. So I think we don't know much about it. Probably I would just suggest not to, because we monitor our patients with potassium monitoring. And I see the confidence with which a lot of people prescribe eplerenone the minute the patient comes into the clinic with so many medications. I would just say a word of caution.
Okay. Micropulse.
Micropulse, I really think that it definitely has a role, particularly in CSC. We have done a lot of work on that. I think there could be, but the only thing is that we end up offering micropulse or thinking more about the patient. By the time the RP is already so much damaged, then now you are dealing with much more advanced disease, where the disease has progressed so much and now nothing is working. So I think that's why the right time and the right treatment is something which we should definitely be exploring.
I just wanted to comment on that scleral resection, the scleral flaps that you were doing. Didn't look like a thick sclera at all, because it works if the sclera is very thick. And these thick sclera, even if you resect 50%, we usually use the trabeclectomy guide. Even then, you can't see blue choroid underneath. So I'm not surprised it didn't work, because when you resect, when you retract and you see blue sclera underneath, which was very bluish before you started resecting, I don't think it would work in that case.
And in the same thing, it is not necessary that every pachychoroid or every chronic CSC will have thick sclera. So again, we need better imaging to understand which mechanism is playing a role in which patient.
Yes. So Pratibha, can we have you on the dais and on the podium? Means she will be talking to us about the pachychoroid algorithm, which is useful for the clinicians. Huh?
Yeah, thank you all. I'll be just simplifying the whole talks what we had in the since morning, what we were listening. So we thought we just bring about a pachychoroid algorithm. It might overtly look a little bit oversimplified, and of course, considering the lot of complexities and the dilemmas and the imaging questions that we are having, definitely it does look a bit oversimplified. But I think this basic understanding might be of great benefit to the clinicians to at least come to some conclusion as to what they're dealing with in the day-to-day clinical practice. So without much ado, let us just delve into it. The thick choroid on OCT is something we all come across. So if there is thick choroid as well as thick vessels is when you have to identify this in the beginning. So the next part of it will be to identify where the thick vessels are, whether they are deep dwelling inside the choroid or are they rich abutting the RPE. So this simple, you can see that this is a condition where you have an acute CSCR and you have the thick vessels which are deep down and they are not having any effect on the adjacent satellars or the choricapillary alterations. So this is an acute CSCR. On the other hand, you have the thick vessels which are much more closer to the RPE, causing a compression effect on the satellars and the choriocapillaries. And you can identify this as the pachyvessel-driven pachychoroid diseases. So now let us move on to, once you find out that there's a pachyvessel pachychoroid disease, what next? So identify whether there is any RP irregularity or not. So once you find that there are some RP irregularities or abnormality, and this is the only feature what you're seeing there, then probably what we're dealing with is pachychoroid pigment epitheliopathy. So now look further and see if they are seeing some kind of a neovascular component. As we were discussing now, presence of a AA sign, or the presence of a thumb-like projections, or if you're seeing some hemorrhage, exudates, that should drive us to think whether we are dealing with a neovascular component. So an OCT angiography or better still an ICG angiography can throw light onto it, and we will be able to identify either a PCN or a PCV lesion. If this neovascularization component is ruled out and we are dealing only with RP irregularities and it is very, very subtle, few changes, as Dr. Vishma told, some small white dots there in the posterior segment, then we can be just having a pachydrusen. If these things are more extensive and you're seeing telltale signs of previous fluid or current fluid, then what we're dealing with is CSCR. So just if none of these features are there, neither RP irregularities, but only a pachyvessel and a pachychoroid, then it could be an uncomplicated pachychoroid disease. So we will just drill into a little bit of clinical scenarios. So if you look at the OCT there, you can see that it is a Pachy vessel, Pachy choroid. You can see the adjacent attenuation of the choriocapillaries and sacculus layer, but you can see also a double layer sign. This is what was discussed when to think about a neovascular component. So we have high index of suspicion, and of course in this patient it's quite evident. We saw a thumb-like projection, and definitely an ICG showed the presence of a polyp and a BVN. And this is a chronic active CSER because we do see the fluid on the temporal side there, and with the PCV-like lesion. And this is another patient who, again, has the typical features of a Pachy vessel, Pachy choroid, but you also see a double layer sign there. And when we went ahead and did an ICG here, you could see the clear, the BVN, the branching network over there. And this is a Pachy choroid neovasculopathy in a patient with chronic inactive CSER. So this algorithm can help us to identify the final condition what we are dealing with. Now, suppose you're not able to see the visible dilated choroidal vessels on OCT, then we go on to the right side of the algorithm, which is whether you are dealing with a thicker choroid, which is diffuse and more extensive, or you're dealing with a thick choroid, which is more focally present. And in these cases, again, so this is a diffuse thick choroid and a focal thick choroid, more localized thick choroid. So again, in this, again, we need to rule out the possibility of pseudochoroidal thickening or apparent choroidal thickening. I think that will be dealt with Dr. Ramesh in the next talk. And to identify this apparent or pseudochoroidal thickening, as we were mentioning that there are a lot of imaging parameters which take place, and thereby we might actually end up seeing an apparent choroidal thickening. This usually happens when there are pigmentary changes, and loss of pigment in the choroid can reduce the dampening effect of the light passing through, and thereby you might be actually seeing the choroserial junction so prominently that it might give you a false appearance of a thickened choroid. So once you have ruled out the possibility of a apparent thickening, then coming back to the diffuse choroid, you are now evaluating whether these patients have got any kind of a inflammatory condition, infiltrative conditions, or a congestive condition, or some kind of a genetic condition like the posterior microophthalmos or nanophthalmos. So if these things are not present, it can still have a diffuse thick choroid depending on the hyperopic characteristics and the ethnicity of the population. So leaving this aside, so this is another patient where you can actually put in the algorithm. You see a thick choroid, but you don't see dilated choroidal vessels. It's a diffuse thick choroid with choroidal undulations. Again, when we did the FA for these patients, you could see the pinpoint leakages and profuse leakages in disc hyperfluorescence in late stages. This is a case of Harada's disease. So again, there's a patient who walked in, a young patient who walked in with headache and dizziness. Again, a diffuse thick choroid, few hard X-rays in the retina, and coexisting hypertensive retinopathy, and I think it's a hypertensive choroidopathy patient. So again, diffuse thickening of the choroid. So if we come back to the central part of the algorithm, we can see that if you have a focal thick choroid, what next? Again, this focal thick choroid is a little bit of a controversial condition. So if you see more amount of this focal thick choroid in the macular region or outside the macular region. So in the macular region, having ruled out the focal inflammatory conditions, the most common conditions which we come across as a focal thick choroid is usually the alteration in the sclera, which in turn causes the choroidal congestion. So coming to the dome-shaped maculopathy or the staphyloma-induced maculopathy, wherein you have an alteration in the sclera, and thereby there is a localized choroidal congestion giving rise to the fluid collection. And now moving on to the outside the macula. So suppose there's a focal thick choroid which is outside the macula, it is important for us to identify whether it is peripapillary or peripheral. The peripheral congestion of the choroid is usually is when we call it as PHCR. Again, this is highly controversial whether PHCR is a part of the Pachy choroid disease and what exactly causes PHCR, whether it's exudative or a neovascular-driven condition. But definitely there is a consensus that peripheral congestion of the choroid, in fact, is responsible for the PHCR. If it is a peripapillary Pachy choroid syndrome, we find that the congestion is more so in this, around the optic nerve, and thereby it is a slow effusion of the fluid into the choroid, into the retinal spaces, and thereby we see the effect of the peripapillary Pachy choroid syndrome in the surrounding area around the optic nerve. So I think this algorithm, of course, as I mentioned before, I started with a disclaimer, it's oversimplified, but I think it gives you a good idea about starting off with whether there is a thick choroid and a thick vessel, and moving on to finding out whether it's a diffuse thickening or a focal thickening, and identification of these parameters can bring us to somewhere close to the diagnosis. Thank you.
Yeah, Jay, your thoughts, ma'am, your thoughts on the algorithm itself? Yeah. Just so I'm skipping my talk, so we'll be finishing.
Very nicely done, Pratibha. Probably before thick choroid on OCT, I will put lack of fundus tessellation on clinical exam.
Okay.
Because we think we are a highly pigmented race and we don't see fundus tessellation. But now I think if you look carefully, you see there's lack of fundus tessellation, then you ask for enhanced depth imaging and then look for thick choroid.
Okay.
And then the minute you see that, then you start looking, am I looking for the other abnormalities? That's probably what I would add.
I will just add one thing, at least for the audience also, that don't make the diagnosis of Pachy vessel just by looking at one single scan. That is like almost a crime.
Okay. Thank
Great
you.
work.
Thank you, everyone. Thank you for this instruction course. It was a very enlightening experience. Thank you. We'll have a photograph.